Thank you, respected chairpersons. At the very outset, I would like to thank Dr. Alok Kanungo for having given me this opportunity to interact with you. And as respected Dr. Das and Dr. Kaur has mentioned,
Dr. Ghosh,
yes, please.
Sorry, I'm just from the technical team. I just wanted to make sure if it's possible to increase the brightness in your room. Your face is, as in the light is coming from behind you, so it's too dark.
Right. Okay. Let me try and turn around.
I'm not able to see you too well. Yeah, it's much better now. It's much better.
So I'm going to try and talk about SGLT2 inhibitors and its effects on the kidneys, and whether this group of drug can actually halt the progression of kidney disease in patients with type 2 diabetes. Just a quick recap that, even in the United States, there's been a huge increase in the number of people who are developing end-stage kidney disease. And if you look at in the last 3 decades or so, the numbers have gone up exponentially. And worldwide, and even in the United States and in India, at least 50 to 60% of all kidney disease and kidney failure is actually accounted by diabetes type 2. The demand study, which actually looked at the prevalence of kidney disease worldwide, has shown that almost about 30 to 40% of all patients with type 2 diabetes will have some degree of renal involvement. Now, in India, if you look at about 8 crore people having diabetes, and if you say 40% have some degree of renal involvement, you are talking about more than 3.2 crore people who have a problem. That's the kind of magnitude. And what's also is that people of Southeast Asian origin have higher renal involvement compared to the Caucasian population, which is again very alarming. And we look at urine albumin creatinine ratio as a marker of endothelial dysfunction. And what has been shown is that the worse your urine ACR is, the greater is your risk of progression to end-stage kidney disease. So higher the amount of protein that is leaking, greater is the risk of progression to chronic kidney disease and end-stage renal disease. And we know the greater the ACR is, the greater the risk of cardiovascular mortality and all-cause mortality. So we are not just talking about one bit of the problem. So the kidney and the heart, they all go hand in hand. Therefore, if you are able to prevent something going wrong in the kidney, you will probably improve cardiovascular mortality and all-cause mortality. So that's where the importance is, because not all patients with ESRD are going to die of kidney disease, or patients with renal disease are going to die of kidney disease. They're predominantly going to die of cardiovascular disease. And the last time we had a drug which improved renal outcomes, whether in patients with diabetes or without diabetes, is from the ACE and the ARB studies, the renal studies and the IDNT studies. That's almost 2 decades ago. So ever since then, what we've understood is what's important to prevent chronic kidney disease. Number 1, good blood glucose control. Number 2, good blood pressure control, and preferably the use of an ACE inhibitor and an ARB group of drug. But since then, we've not had any other new drug for renal protection. Now, if you look at the SGLT2 group of drugs, normally what happens is when the glomerular, it filters out glucose and sodium, and in the proximal convoluted tubule, the glucose and the sodium is reabsorbed through the SGLT2 receptor, as a result of which the amount of sodium delivered to the macula densa in the distal convoluted tubule is relatively less, and the afferent arteriolar tone of the glomerulus is relatively well maintained. But when individuals have diabetes, there's an increase in eGFR, and if you use an SGLT2 inhibitor there, it will inhibit the reabsorption of sodium as well as the glucose in the proximal convoluted tubule, as a result of which more amount of sodium is going to be delivered to the distal convoluted tubule, and there will be alteration, or most importantly, what happened normally is vasodilatation is supposed to happen. That's going to be altered. So there's going to be an alteration of the tubulo-glomerular feedback in individuals with diabetes, which will be improved upon by the use of the SGLT2 inhibitor. So if you look at this particular diagram, you can see on the left-hand side, before the use of the SGLT2, the afferent arteriole is dilated. After the use of an SGLT2, the afferent arteriole is constricted, essentially telling us by doing this, you're reducing the intraglomerular pressure. Now, this is one of the several postulated mechanisms through which SGLT2s might be doing benefit at the level of the kidney. Now, the first of the studies that we had looking at renal outcomes and kidney benefit was the EMPEREG trial, then you had the Canvas program, and then you have the DAPA-CKD, the DECLARE-TIMI. Now, in all of those three studies, you've got to remember that they were cardiovascular outcome trials, and that the renal outcomes were all exploratory. So all of those exploratory data suggested that SGLT2s were going to be good drugs as far as the kidneys is concerned. But the two renal outcome trials of the ROTs, the first of which is CREDENCE, and the second is the DAPA-CKD. And we have several other studies in the pipeline. So if you look at the CREDENCE, it included individuals more than 30 years of age with type 2 diabetes, uncontrolled glucose, eGFRs between 30 to 90, and with urine albumin excretions more than 300. And they were already on an ACE or ARB at a stable dose. So you are trying to figure out whether over and above standard of care, whether this group of drugs were going to do any benefits. And after a 2-week placebo run-in period, individuals were either started on canagliflozin 100 milligrams or placebo. And if you look at the renal outcomes that were looked at was end-stage kidney disease, doubling of serum creatinine, renal deaths, and cardiovascular deaths. These were taken together as the primary endpoint. And if you look at the primary endpoint, the results were dramatic. 0.40s and a 1, clearly reducing the composite endpoint by 30%, which is dramatic considering the relatively few number of people that was actually there in the CREDENCE who had relatively bad kidneys. And if you look at the end-stage kidney disease, doubling of creatinine or renal deaths, the benefits were even more dramatic with almost a 34% reduction. In terms of the end-stage kidney disease looked at individually also, there was a 32% reduction in the total number of people who reached end-stage kidney disease. And if you again looked at the other endpoints of dialysis, renal transplantation, and renal death, that too had a dramatic 28% reduction. All of these individual components of the primary endpoint, you can see almost all of them were significant. So this just tells us that, this drug works across the board in terms of all the renal parameters that we are actually talking about. And if you look at, the decline in the eGFR, which normally happens, you can see that the slopes are entirely different. And in the placebo group, where the loss used to less than 2 mils per year, essentially telling us that you are going to improve the renal decline by more than 60%. And if you look at the individuals of patients and say, okay, I'm going to look at the bad patients versus the relatively better patients in terms of primary prevention and the secondary prevention cohort, because people who already had bad hearts, you would expect that they are going to have better benefits because they are at higher risk. But if you look at in the subgroup analysis to look at primary prevention versus secondary prevention, there was no difference between the groups, essentially telling us that the kidney benefits happened across the board, irrespective of your baseline cardiovascular risk, which is again very, very dramatic. And if you look at the numbers needed to treat for the renal benefit and the cardiovascular benefits, the numbers are very, very small, telling us that you need to treat only few patients to actually achieve great benefits. And even if you looked at across the eGFR spectrum, obviously the ones who had worse kidneys had even better outcome. And you needed to treat only 16 patients with eGFR between 30 to 45 to get benefit in the primary outcome. Now, this was followed up last year by the DAPA-CKD trial. Now, what's important in the DAPA-CKD trial compared to the CREDENCE is that you have individuals with not only diabetes, but individuals without diabetes. So essentially telling us, is this drug going to act across boards? And here you had individuals with eGFRs which were worse than the CREDENCE group and had ACR which was increased. They were on stable doses of ACE inhibitors and ARBs, and with and without diabetes. You essentially randomize them to either 10 milligram of dapagliflozin or placebo. And if you look at the etiology of chronic kidney disease, because this is important, because the mechanism that I spoke to about was about reducing intraglomerular pressure. Here you have a mixed bag of people with chronic kidney disease, not necessarily glomerulopathies. You had other forms of kidney disease as well. So essentially telling us if the drug works here, it's probably going to work in all different kinds of kidney problems, not just glomerulopathies. Now, why that's important? Because a lot of times we don't know whether our patients with type 2 diabetes involved has true diabetic kidney disease or might have even non-diabetic kidney disease. And this group also includes individuals with kidney disease without diabetes. And if you look at the primary endpoint, which is again similar to the CREDENCE group, there's almost a 40% reduction in the primary endpoint. Dramatic reductions, dramatic benefits with dapagliflozin. And if you again look at across the board of those individual components, you can see that there's great benefit of all of those individual components. And even if you look at the secondary outcomes, similar to the primary outcomes, and all of these endpoints like renal replacement therapy in the form of dialysis, transplantation, all of them getting improved dramatically. CV death and hospitalization for heart failure, not surprisingly, dramatically improved with this group of drug. All-cause mortality dramatically reduced. So again, you have a drug now here in individuals with kidney disease, where not only are you improving renal outcomes, you're improving cardiovascular mortality and all-cause mortality. Not surprisingly, because at the beginning of the talk, I told you that individuals with bad kidneys are more likely to have greater cardiovascular events and greater all-cause mortality. So therefore, if you improve renal outcomes, you would expect to improve cardiovascular mortality and all-cause mortality. So a summary of the DAPA-CKD is you can again see across the board dramatic improvement in all of these parameters. So if I have to stop here and summarize the take-home points, number one, we realize that we've got a huge burden of diabetic kidney disease. In India itself, probably we have 3 crore people with type 2 diabetes with some form of renal involvement. We are all aware of the current standard of care, which includes good blood glucose control, good blood pressure control, and use of an ACE inhibitor and an ARB group of drugs. What now we have added to that armamentarium is the use of an SGLT2 drug. And if you look at the European renal guideline, it says even if an individual has got good blood glucose control, but has renal involvement, it is warranted that we stop the anti-diabetic drug that was being used and replace it with an SGLT2 inhibitor. And it is 2 decades that we've had to actually wait for a new group of drug to improve and slow the progress of kidney disease in type 2 diabetes. And SGLT2 is the new kid on the block. I shall stop there for any questions. Thank you very much.